some, you know. Oh, there's Victor. Victor's here. Good, 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 good. Great. You know. Oh, there's Victor. Victor's here. Good, 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 good. A few things. Hold on, Victor. I'm coming to you. I'm just putting some vital information on YouTube, so we can televise on YouTube, which is actually the place we get the most viewers. Let me just check that. Can televise on YouTube. There we go. Which is okay. Yeah, we're ready. Oh, you haven't met Victor. He's a character. Victor,
Hello, dear professor.
¿cómo estás? How you doing?
Muy bien, very good.
I want you to read Atta Bhatti. He's the gentleman that has the organization that is doing a lot of the stuff we're trying to do, reach the third world, neurosurgery. Say hi, Atta, the Victor.
Hi, Professor Victor.
Hello, how are you?
Good.
This is Victor Hugo from Mexico City.
Yes, I already know and familiar with the work
He
you're
says you're a
doing.
he says you're a big name, Victor.
Yes, that's not the exaggeration.
Well, it's a lot of work. It's I've been with Victor for a while. We've been broadcasting. We must have made about 200, right, Victor? Maybe more.
Maybe more, yes.
Yeah, he's got quite a record, archive, and I sent you ones, but they were in Spanish because we've done them in Spanish, and he's also done a lot in English. And because of Zoom and Google Hangouts, Victor now travels a lot. He goes a lot, and we're a part of that success, right? Right, Victor?
Yes, thanks to God.
Yeah, and God
I'm
too.
traveling. I'm traveling several times by year, almost 2 or 3 times. Next week, I will be in England. I was invited to give a conference about spinal cord vasculature, specifically in Cambridge. There is going to be held a congress, and we are almost 40 brain surgeons around the world. So I'm happy to go there and also to stay here in this
Well,
conference.
we'll try to broadcast that one because we had Cambridge Neurosurgery Grand Rounds a couple of weeks ago. Mario Ganau is his name. Oh no, I got confused. Oxford, Cambridge. Do you understand that, Ada? The Oxford and Cambridge relationship or rivalry? Is it like Yale and Harvard? Similar to that? Do you know? Because Yale and Harvard are considered the big Ivy League schools, and they kind of have a rivalry, Yale and Harvard. Anyways, uh,
Don't probably one gynecologist from Oxford. Her name is Dr. Bismi. How did she join?
I'm sorry, I wasn't listening.
One of the gynecologists I invited, if she's not busy in hospital, she will join.
Sure, we love to broadcast her. If you think it's relevant and good for the neurosurgery community education, yeah, we'll televise it. We'd be glad to.
But
That's
this,
why I'm glad I met you. I can get leads like that. You know, and Victor will do the same. When Victor travels, I think sometimes he says, oh, you know, call John Bennett or something. That's how I do a lot of the webcasting, referral from doctors. But okay, why don't we start, okay? Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2. Good day, this is Dr. John Bennett broadcasting from Miami Beach, home of Neurosurgical TV. We have the honor of having Atta Bhatti, the head of an organization that basically is doing the same thing we're trying to do, is to educate the neurosurgery developing countries. And I'll introduce Atta right away. And Atta, please tell us about you, your organizations, and we're gonna introduce Victor. Victor is a very loyal member of this webcast. We were just talking about it previously. He was nice enough to come here to lend his expertise. Okay, Atta, it's all yours.
Thank you, John. Thank you, Victor, for providing me this opportunity to utilize the Neurosurgical TV forum for this initiative. I am a hybrid trained neurosurgeon uh, and interested in developing countries, lower middle income countries. So I have experienced working in Asia and Africa, and now I have founded an organization with the name of Neuro Healthcare for LMIC in Geneva. So we have two co-founders, Dr. Bern Dobler, neuroradiologist, and Halim. So we try to do everything to improve neuro healthcare for LMIC by teaching, training, and clinical activities. And last time I presented in detail regarding my organization and its structure. So we started this since I was involved in general neurosurgery and pediatric neurosurgery. So we, in lower middle income countries, we used to see a lot of neural tube defects. So this is something very close to my heart. We started these sessions. We went through the journal embryology, right from the fertilization to implantation, and then after implantation, we went through the initial phases of germ plate layers. We also did see how the induction of ventral and dorsal plates happens, and then how the early phase of embryonic development happens. So I believe that understanding human embryology is fundamental to understand different pathologies, including the neural tube defects, the dysgraphisms, also all the neurovascular pathologies, understanding their natural history, and predicting what is the best treatment modality and the effect of treatment follow-up. So that gives you a lot of understanding of vascular pathologies. For example, neural fistulas, brain avians, and also provides you an opportunity to strengthen your pathophysiological understanding. for example, you go through the various factors of dynamic vascular structure happening to change its course. Sometimes there comes a complete healing. The other times the things becomes bad to worse despite all the managements. So today we will focus on some revisions, some repetitions. It's meant to address a very basic level to medical students, neuro aspirants, junior residents, and junior surgeons. So Victor is here. So um, Victor will keep guiding us, keeping us to the track, and we would be happy to have his input and further explanation of neuroembryology and neuroanatomy's importance in neurosurgical practice. So being a hybrid neurovascular trained neurosurgeon, I am focusing to improve my basics. So I would be happy to learn from all the colleagues and please do stop me at any point during my presentation, and I would be happy to uh, discuss things. So let me just tell you some interesting facts. This was 1965. This Swedish photo journalist Leonard, he was very much interested in seeing the human pathology, and in those days, the Swedish laws were very liberal to abortions, and his work was done very first time from the very blurred ultrasound, poor quality at that time, ultrasound gray and black, turned into the colored one. And the Swedish, this was the most, his book in the form of A Child is Born was based on these human aborted fetuses by the mother, legally allowed at that time. But this became a campaign for the pro-life groups, and this was the history. But it also shows a keen interest of the overall humanity, knowing how the human development, the miracle of human development happens. This book was the bestseller. It went to the space on the NASA probes voyage, Voyager 1 and 2. Millions of copies were sold. This was the icon book of the time, and still had more than 4 editions. And you can see that this gives a very good insight to those days. Imagine it was 1965. Now we have 3D and 4D ultrasound. We have better imaging facilities. But this book also had another human emotional touch. So the touch of having the parental side of this, that was the second part of this book. So that was about this book. So now I'm just trying to go back to a very basic slide, which is showing that the embryonic, fetal period, and perinatal period are the 3 main divisions of how the embryonic growth happens. So this is based on Accardi in 1992. So we see the various terminologies used in various books. So what we are seeing here is the stages, the time of occurrence. So the human-like embryo formation is almost in the middle of the pregnancy. And before that, a lot of dynamic processes keep happening. And the development begins with the relatively simple formations, the folds, invaginations, cavitations, condensations, and dispersion of cell groups, which we call very organized migration processes. So the end of this process of many folds and vagination is the result uh, uh, of a product which is a complex organ, and in order to guarantee that the integration of the assembly, the process going on in the different regions can be very harmonious, regulated, and sometimes it's a mosaic-like similar thing happening everywhere on the embryonic part, and the other times the one step growth leads to the secondary changes, and embryo have to be interlocked in space and time with great precision. So this morphogenesis is a highly regulated and influenced by many modulators. So we are not going to the details of those those modulators today, but with gradual sessions, we will choose those as well. So uh, there are the triggers and timings which are important for the growth of this embryonic period. For example, this is the time when neurulation occurs. The neurulation is the process, as we already discussed, in which the plate-like two-layer embryo after the trophoblast and the blastocystic stage and morula formation and implantation, the two-layer cell converted into three-layer, and um, this ecto endo and mesoderm leads to the three-plate formation. And this neurulation is actually the neural plate formation and then tube formation. So embryonic period is also called as post-fertilization and post-conceptional period, and it's first to 8 weeks. As we see here, this slide, this table also shows that why it's important for neurosurgeons to know these periods of brain and spine dynamic growth. So brain is the first organ which develops. Even before the establishment of the full-fledged cardiac circulations and vascular segments, there is three cavity like structure formation, hand to hand and neck to neck. So these cardiovascular pharyngeal arches and the brain and spine formation happening in this critical timing, and this 2 weeks formation and separation of germ cells, neural plate is the major morphological event at that time, and any problem, any insult to embryo can lead to any imperfection due to any reason. Could be genetic, could be nutritional, or any other insult to the growing embryo. In the modern era, amniocentesis related also reported cases are there where the amniocentesis needle hurt the process and leads to icrodelic problems in growing embryo. This is called as the split notochord syndrome at the stage of 2 weeks. So later on in the 3rd to 4th and 4th to 6th weeks, dorsal induction or primary neurulation process in which the neural tube, neural crest and derivatives are formed. Closure of rostral and caudal means the cranial and the lower end happens. Both neuropores and alar pair plates formation happens. So this stage deformity can lead to anencephaly, encephalocele, myelocystis, myelomengocele, carry malformations, etc. And in the ventral induction phase, which we also call as telencephalization, so the formation of telencephalon is in the week 4 to 6. So in this period, there is the formation of forebrain and facial structures. So the cerebral, vesical, optic and olfactory placodes, rhombic lips appearance, and fusion of cerebellar plates are the event. So any um, abnormality leads to hollow prosencephaly or Dandy-Walker malformations, craniosynostosis. So as the embryo, I'll show the pictures later on in next slides. But here we are covering that after the 6 weeks till the 24 weeks of the gestation, this fetal period starts and the neuronal and glial proliferation starts at 6 weeks and keeps on building up different migrational sequelles of neuronal elements to form the different components of central nervous system, and also the migration process starts at the 12 weeks time. So this cellular proliferation and ventricular and subventricular zone, that's typically the most dynamic site is the subventricular zone, where the early differentiation of neuroblasts and glioblast cells happens under the influence of mediators. So there are many neural cells. There are many neural cells can no longer takes parts in the formation of embryo, and that is the process which we call the apoptosis or deaths of those unwanted neuroblasts and neuronal cells. There is a migration of Purkinje cells, external granular cells, and this is the stage where microcephaly or megalencephaly can happen if there is something wrong with the glial proliferation. So similarly, in the migration during 12th, in the mid of that glial proliferation, the mature cells from the subventricular zone, they start migrating to the cortical neurons, and there is also formation of corpus callosal structure, so interconnection of both hemispheres happens. And amongst the most prominent neuronal migration disorders are lissencephaly, polymicroglias, schizencephaly, and heterotopia. In the period 24 weeks beyond, there is the organization of these migrational neuro cells, and then after the birth till the 2 years time postnatally, the myelination keeps happening. So the late migration, maturation of cerebral cortex, synaptogenesis, formation of internal granular cells layer in the cerebellum happens in the late birth stage of 2 years time post. So myelination disorders and destructive lesions secondary to acquired injuries are common at this stage. As we see right from the start of the embryonic period till the myelination, you can appreciate that the embryo and the growing brain and spines are vulnerable to the abnormalities due to various factors. This slide is showing the actual pictures of various fetuses right from the earliest phase. You see that this slide is showing the age of the growing fetus, growing embryo in weeks. So here, the 6 weeks before that, at the 5 weeks time, you see very small structures, and then this, no matter it looks very small, but a lot of processes, vascular and brain cavity formations, the neurulation processes already start at this 0.5 centimeter or even before that. So in the 6 weeks, we can obviously see the optic placode, the upper limb and lower limb initial buds, the overall structure the trunk. The 8 weeks similarly is showing further growth of these structures. The pharyngeal space, the head and neck is most vibrant. Developmental structure at that time. At 12 weeks, there is more medial location of the eye, and laterally located ears are visible. The mouth and the elbow and forearm starts, and webbing of the hands also starts at the age of 16 weeks. Similarly, you see more human-like 34 weeks, and then at the time of maturity, you see the Lugano hairs and other gestational features, advanced fetus features, including the maturity in every organ. And of course, we see the skin, the hair, the more human-like upper and lower extremities and face. So we just try to mention that we just try to understand that at the junction of the cranial and the caudal, the rostral side, there are some very special cells migrated as the rhombomere cell migration, and in the form of cell migration. This is the process what we call as the bronchial arches, and it has all the components of the central and peripheral nervous system, as well as the cranial nerves and other facial structures, which we just try to understand and understand the terminology in today's session. So there are initially the 6 arches. The first one has a portion of the maxillary artery. The second has stapedial artery, and the third will be a precursor of common carotid. And similarly, the fourth on the left side makes the segment of the aortic arch, and on the right side it makes the subclavian pulmonary arteries, and the 6th pulmonary trunk and ductus arteriosus. The 5th one regresses, and these rhombomere cell migration and derivatives within the pharyngeal apparatus leads to the formation of the vascular, the cranial nerve, the other features of faciocranial base. And just to give you an idea what vascular structures at what times becomes so dynamic, and here Paget reported this. She was the leading embryologist, and her publications for vascular are still very precisely showing the fine details. And it was in 1948 when she published her work, and she worked with the Cushing's and other renowned anatomist and embryologist of that time, including Steer, also had the similar publications in that era. So the Paget stage 1, it was the Paget stage 1, but we try to follow the Carnegie stage 1, and I'll show you it in next slide. So this here you see it's the 4 to 5 millimeter. That means 0.5 centimeter embryo, 30 days of the age from the last. So clinically we see the last menstrual day is the timing when we start the day 1 for the growing embryo. So that means that it's a very tiny cellular structure, and showing a lot of segmental arteries, the the developing nerves and numbered from 5 to these are the future segmental arteries of the spine. Here you see the different vascular element from the pharyngeal arches. So starting from the fourth, third, and then you see there are the cranial ICA, uh, the initial structures. So what happens is that the ICA divides into two, the mainly the cranial division, and the other one is the maxillary arteries, also visible in ophthalmic artery. Okay. So the anterior circulation which is forming here will supply all the anterior part, and here you see the cavities of the brain already formed from the tubal structure, and we see that C1 to 7 pharyngeal arches are also visible there. It's the anterior posterior and it's the mid sagittal or sagittal image. So as we see the remnants of bronchial arches or arteries uh, uh, from the first mandibular artery becomes the intermediate. So there are some arteries which becomes the remnant vessels, the adult vessels. Others they regress in the intermediate time, and the similar way in the second bronchial arch, the dorsal branch of Hyde and stapedial is the intermediate arteries, and they finally form the corticotympanic arteries in adult remnant adult remnant vessels. So the bronchial arch third and fourth forms the proximal internal carotid artery, and the fourth, the right proximal subclavian, and on the left side, aortic arch. And similarly, the sixth one makes the ipsilateral pulmonary artery and leftist arteriosus. So this is the 10 stomites. Stomites are the paired structures on the paramesodermal space, as you see the pair. So this 10 stomite stage is before the complete closure of the neural tube. So you see the cranial and the caudal pores still not completely fused. So and in the cross section, you see the future notochord, the paramesoderm, the myotome, dermatomal spinal elements in initial stages, and the abdominal organs which develop later in the growing embryo. So as you see, the further section, it's not a straight vertical structure. So this is the cranial and this is the caudal. So we see the ventral and dorsal. So it's like the neural tube process is showing some kyphotic curves, and primitive streaks is visible, primitive knots and cloacal future rectal and anal canal amniotic cloacal cavities, the openings, these are also can be identified here. So umbilical artery, elantritis, and the posterior intestinal portal are also visible in this. So the notochord formation happens by the stage, by this stage, and is identifiable. So here you see the neural tube, neural canal. So this is the rhombomeres. So rhombomeres are more developed in the early stages, and later on there is the mesencephalon and prosencephalon development in the later stages. But in the early rhombomere formations, and rhombencephalon is more visible, and you can also appreciate the oropharyngeal membrane structures, the cardiac structures visible here anteriorly, and primitive yolk sac is also located in the pericardial sac region. So, as I showed you, so there is the Carnegie stage system for the development uh, uh, understanding of different stages. So, since the identification of the first few days are very difficult, and the tiny 1 mm stage was labeled as the Carnegie stage 8. In fact, the day one of the fetus, or stage one of the fetus, is when there is a fertilization of ovum and sperm. So naturally, we are starting from the 8th Carnegie stage at the 23rd day embryo, where the neurulation, neural fold and groove is visible, and I'll show you it later. As we see that the 1 to 3rd, so the day 23rd is the day when the somite. So it's generally after 20 days of the embryo, every day 1 or 2 somite formation happens. So at the 23 days, we can see 3 somites. There are the neuromere formation appearance. Also, as we advance in the Carnegie stage, there is the corresponding increase in the size of fetus length from 1 to 2 millimeter, and by the time the developmental stages reaches to the Carnegie stage 12, it's the 30 days gestation, 30 days gestation, 4 millimeter, around 4 millimeter length, and here the neuropore, caudal neuropore, secondary neurulation is already finished, and adenohypophyseal pouches are already forming, and the number of somites pair becomes towards the maximum side from 21 to 29. And as the fetus grow further, we see gradually the future cerebral hemispheres, the flexures. So there are main pontine flexure formation at the age of 33 days and 14th Carnegie stage. So similarly, we see the olfactory tubercles, dorsal thalamus formation, and advanced brain structures in next stages. So there are 23 stages in these embryonic period times, and by the 23rd, the insula is formed. The external capsule, chordate, putamen, they can be recognizable. And similarly, we see at the Carnegie stage 20, choroid plexus and lateral ventricle, and optic interpedunculaar nucleus, septal nucleus, they are also identifiable. So it's the 56 days, the end of the embryonal time. So to recap, neurulation is a process which follows the fertilization. There is the divisions initially of cells from 2 to 4, then morula stage, blastocyst formation, blastopore formation. And just to show you some features by the stages, and to give you an idea how the tiny 1 to 1.5 millimeter shows the neural groove and folds. This is the first indication of neural groove when it's tiny 1 millimeter at the stage 8. And this is very crucial and important organizational stage. The primordium of the brain appears before the heart, as I already mentioned, and this makes the heart the most first or most premium organ to develop in fetus. So, revision of gestulation concept. So burrowing movements of cells on the neural plate resulting into a thickened two-layer, initially the plate-like formation, then of two-cell embryo, which is what we call gastrula. This two-layer leads to the ectoderm, endoderm, and then there are streak formation, and then pitting, and then invagination leads to the mesoderm. And notochord and neural tube formation is also the continuity of the same process in which the mesoderm begins to develop. Mesoderm is the second layer. The invagination leads to the formation of mesoderm, the middle layer or mesoderm, which is um, uh, begin to develop in a tube called notochord, and it leads to the formation of different the mesoderm in the middle, and this myotomes and dermatomal components. Each one has its own muscle, nerve, vessel. So this raised edges of the neural plate on the lateral para median sides, they form the head and tail of the embryo, and there is a lot of migration. And this is the picture which shows how the neural plate formation gets these folds, and then the roof plate cells, they forms the neural crest on the lateral, and the neural tube formation happens with the roof plate cells invaginating inside to form a tube structure. So this is what the neurulation process is, and how it looks like on the cross sections of the embryo in the sagittal plate, in the and sagittal and coronal plane. So these are the stages from the primitive strake, the stage 8, 9, 10, and this is what is the neural crest at the 10 somite stage. Still, the pores are not closed. So as we see that the ectoderm has skin and neurocutaneous structures. In future, pia, arachnoid, glia, ependymoma, neural parenchyma, and skin, as well as so we see a lot of neuroectodermal combinations in the signs and symptoms of various disorders affecting the growing embryo, and described in details, like the faciocranial disorders. Mesoderm cells form the muscle, bone, and the dural linings, as well as skull vertebrae and the spinal bony components. So endodermal are more into gut and internal organs. So just to show you that on the stage 9, how the 3 major divisions of the brain can be distinguished. So this is the head fold and the waist-like structure where the rhombomere formation starts. So this is the lateral view where we see the different curves. The caudal end shows allantoic diverticulum, and the future terminal cloacal and rectal ends. Primitive groove and the caudal eminence. This is the bulky structure which is on the caudal side. Primitive pit and node, the future neural tube area in the midline. So here we see these bulges as seen on the sagittal images. So these pictures capture the different Carnegie stages from the initial implantation, stage 6, then 7, and then more somite stages till the 11. And here we see that the prenatal age is always there is a difficulty to exactly number the days. There is always a chance of 1 week distribution due to doubtful initial days from the menstrual cycle to the fertilization, end of the menstrual cycle to the fertilization. Generally, um, we follow the ages according to the gestational clinically. So from the first induction of brain to brain formation and different features like ventricles, the brainstem, mesencephalon, rhombencephalon, with the cavities. So these 3 cavities and 5 cavities formation, and the every cavity has its own ventricles. Like the prosencephalon has telencephalon and diencephalon. Um, the the parts of prosencephalon, mesencephalon means the midbrain and the tele, and myelencephalon and metencephalon as the fourth ventricular area structures. And in 12th week, then to 12th postmenstrual week, tentorium and other structures are also formed. So this scheme shows the origin of the central and peripheral system and neural crest formation, neural crest association, and interaction of different events and stages are shown in the bottom of this schematic diagram. Here on the right side, we see the central nervous system and peripheral nervous system, and neuroectodermal, neurosomatic junction, somatoectodermic, the neurulation process leading to the neurulation and the different features till the 13th stage are seen, and how they interact with each other, like this neurosomatic junction leads to the aortic and nasal crest formation. So when we, in the era of ultrasound, um, it's very easy to follow the different growth phases, and for the growing fetus, there are these uh, planes which are being followed as a standard. So the main planes of references and the chief terms of position shown in embryos here. In the A, the body as a whole is seen. In the B, the head is shown with its structures like the prosencephalon and here the mesencephalic picture is visible, and you see the 3 and 5 cavity formation and adult location of these cavities in the full form, full term fetus. So there are 3 divisions, as I mentioned: prosencephalon, mesencephalon, and rhombencephalon. So some divide it into 5 subdivisions and 6 subdivisions. So the prosencephalon has the telencephalon, the cerebral hemisphere. The diencephalon is the thalamus, hypothalamus, epithalamus, subthalamus. And mesencephalon as midbrain. And rhombencephalon has isthmus, metencephalon, and myelencephalon. Myelencephalon is medulla oblongata. And we also know that for the division of prosencephalon, the lateral ventricle and the third ventricle are the cavities for this. Mesencephalon has the aqueduct of Sylvius, which connects the lateral and third ventricle to the fourth ventricle. Right, so same description. So I think we stop here. And we, although we can go further, but it's better to stop here to go next time for stomites and then the actual brain vessel formation details next time. if I just mention the main salient features of the next structures. So these are the repetitions of the same concepts we went through, and we see the growing fetus becoming more human-like, and the brain at the end of the embryonic period, which is the stage 23. So we are at the end of embryonic period, which is the 23rd, 24 week. It's 8 post-fertilization week. Telencephalon is seen in the yellow, the diencephalon in blue, and mesencephalon in brown. So, and rhombencephalon is below. So we started with the neurulation and gastrulation revision. We went through the different components of pharyngeal arches. We didn't go into the detail of pharyngeal arches, which is reserved for the next one. I stop here with this um, anatomy. It's Professor Lesjonias used to show this slide, and this is highlighting how important is understanding the anatomy. This anatomy is a language which we includes much more than the recognition of images. It also involves their interpretation in the unique arrangement of the overall anatomy of the area, region, individual, resulting in the recognition of the difference between a normal variation and a pathological condition. So technological testing cannot replace anatomical knowledge. So in the continuation to highlight anatomy, to understand the anatomy, its variation, its development is very important to interpret the abnormalities and to understand the natural histories and to anticipate the different natural history of the diseases and different treatment options. Thank you so much for your passion and interest.
Okay, Gata, thank you very much for your time and dedication. You said anatomy and Victor's ears perked up. I think
Yes.
Victor's the gentleman that can start the comments. Hey, Victor, it's all yours, Victor.
Thanks, Professor Atta. This is a very interesting topic, not only for students and residents, also for brain surgeons, because as you have said, the understanding of neuroembryology is very important to understand some pathologies, and not few, so many pathologies that we can comprehend much more knowing anatomy and embryology. And as you said in your last figure, anatomy is the cheapest way to be safe, but also to be happy doing some kind of neurosurgical procedures. Thank you so much, and congratulations for this interesting talk.
Thank you so much.
Hey, anybody in the comment, or excuse me, on the panel would like to comment, or even outside in the waiting room, we can post your questions. Here, let me check the Q&A here. Okay, nothing on the Q&A.
Congratulations
Oh,
to
yeah, please go ahead.
congratulations to Dr. Bhatti for explaining everything. And I'll just say one sentence that many a times, if you don't know the embryology, you will tell that these are the variations, whereas these are not the variations. These are the embryological developments which has taken place, and the variations are because of the embryology which has occurred in the anatomy. That is why the understanding of the embryology is very important. And the topic which you have touched is really close to all the neurosurgeons' heart.
Thank you, Dr. Sir.
Suresh, where are you from?
I am from India. I was professor of neurosurgery at PGI Chandigarh, and now I am retired. I am working in Jodhpur. It's a small town, and
Okay.
at present I am in Toronto actually with my daughter for some time, and
Oh,
then
okay.
I'll go back to India. So that's what is the thing, and that's how we started teaching the residents from that it's mandatory to learn the embryology. Without that, you will not be able to learn the neuroanatomy.
Where were you teaching that?
Uh, in PGI Chandigarh, Postgraduate Institute of Medical Education and Research, Chandigarh,
Oh, you
in
have
India.
experience in this, and then you're an old pro. We could probably learn from you.
So I'm just trying to revise and learn something from Dr. Bhatti more, so I can teach my residents much more than what I have already learned.
I think, Suresh, for us, embryology is vital, as you mentioned, and it's little coming out of our comfort zone when we go into territory to understand the and challenge the dogmatic thinking of what, for example, the variation of vessels are being reported, and
Yes,
when we see them in the active neurovascular disease process. For example, if we have uh, a fenestration, the chances of having an aneurysm, and
yes,
how to understand that flow to make a decision. So it's a very interesting area. When we come to dive into it, we come to know that how um, much more we need, how much precise we need to know before we go to whatever we do, clip or coil or whatever.
actually, say when I was working in PGI, we were managing the largest number of intracranial aneurysms in the country. We used to operate, and still we are there. They are operating 450 aneurysms a year, and another 100 to 150 are getting coiled. That is the stage. And when I was there, most of my residents, they had been doing the work on neuroanatomy in the correct cadaveric dissection lab. They have done the dissections of the middle cerebral, anterior cerebral, and internal carotid, cavernous sinus, foramen magnum, tentorial hiatus, all these dissections they have done in the thesis, which used to be covered in MCH neurosurgery. So that's what they are from, and it's really without embryology we can't learn anatomy. That's very important.
A quick comment on that. Now, as a hybrid neurosurgeon, if I understand it correctly, you can handle both situations, correct? You're trained in
Yes,
both.
yes, yes. I
Okay.
have experience with microsurgery and vascular neurosurgery both.
Okay.
And yes, and
Very good. Any more comments? I don't know if Bernd
So
wants to
he's
come in.
he's hybrid, but I continue to be only the operating neurosurgeons. I have
like
clipped lot many number of aneurysms, and that is what we had been practicing. And there are many hybrid neurosurgeons coming up now. Because they are trying to, there are many neurosurgeons who are taking only exclusively the endovascular field, and there are many hybrid. These are coming up in India as well. And
Okay, very good. Okay, as I mentioned, Bernd, I don't know if you want to come in and talk now that we've got the didactic portion more or less over. And there's Fitri from Indonesia joining us. Hi, Fitri.
Hello, John. Maybe I have some question for Professor Atta. Professor, what do you think that an important stage for the from the embryology in the which will develop to be an aneurysm or something or the uh, uh, what is the name? Cerebrovascular anomaly or disorder. Which stage do you think is the most important that it will be a future that in the future the baby will be have a aneurysm or something?
I don't know, is that a genetic testing question, Ata? Is that what you mean? I don't know. Is that what?
Yeah,
It's
yeah.
Is that what you mean? Okay.
it's an interesting discussion, and today we have started to understand the basic steps which make the fertilized uh, embryo into a fetus. So we are trying to go into more details of the fetal embryonic period to see how the vascular structures and other structures are comparably growing. So in future, we will go into what you asked in that question, which is
Oh,
more into vasculogenesis and angiogenesis. So what happens is that there are a lot of timing and trigger mechanisms involved in producing the vascular diseases. So the next stage we will go into detail of development and to this interesting question that, for example, is AVM is a congenital disorder or does it grow with the time? Is it programmed? And it happens to be destined in future based on some triggers during the embryonic life. So this is a very interesting area. So we keep it for the next discussions, and I'm sure it will make us exciting, and we will learn from it from this.
from
And
you.
yes, we will learn from each other, and we try to understand how the triggers are important. And there are classic examples of congenital things like vein of Galen malformation and the pediatric AVM versus the adult AVM. So how the natural history of AVM is, and why these aneurysms. So we see very rarely the youngest one I coiled was 13 years of age, the aneurysm, and we see more the distal ICA involved in pediatric aneurysms. So the youngest one I coiled was 13 years of age, the ruptured carotid T. So to go into more details of how it happens and fetal development of the brain, uh, how it determined to become the pathological or normal physiological, why the AVM is not there in every family member, and things like. So we will discuss it in maybe second or third future session once we go through all that.
Okay, we have a question from Suresh. Suresh, go ahead.
Yes. Say, thank you, Dr. Bhatti. Actually, most of the AVMs are congenital and then they may grow much more. But initially, to start with, they are congenital AVMs.
Okay.
The aneurysms, they may be congenital, they may be acquired as well. And the aneurysms which are in the pediatric age group are mostly at the ICA bifurcation. And the youngest pediatric aneurysm which I operated was a 6-year-old girl who had a giant carotid-ophthalmic aneurysm. So, and there are large number of aneurysms we had been operating in PGI, so we had about experience of the pediatric aneurysms quite a lot. And that's what is the thing. And the say if she wants to read about the anatomy and the development about the vascular structure that Dr. Bhatti has already mentioned, you can go through the article by Dr. Paget. That will be very informative.
Yeah.
And say it's already quoted quite a lot by Dr. Paget in Gray's Anatomy. So you can go through that and you will be able to know about the stages where these malformations start coming up. I think Dr. Bhatti will agree with me on that.
Yeah, it's an interesting discussion, and we'll keep it for the next session.
Yes,
And
yes.
as you mentioned that aneurysm has many phases. So it can be just infective, it can be
Yes.
just dissecting traumatic aneurysm, it can be the classic Berry aneurysms, it can be aneurysm with some sort of multiple manifestations involving the multi-segments. So there is an interesting discussion to come in
Yes.
next sessions.
Yes, yes.
And Paget has beautifully
Yes.
described the embryological development of vessels and including arteries and veins. And we try to go into those details because whole idea to go through the embryo was eventually to make more time on arterial and venous development. That's what we are more interested for this module. So next one, we will be dedicatedly trying to understand the vascular and the Paget steer, and those will be the source references for that talk next time.
Can I keep getting information about the regular talks and these sessions on my mail if I give you the mail ID?
Yes, sure, John.
I'm sorry, you wanted to do a webcast?
No. Say to join the next webinar sessions.
Oh,
if
yeah,
I can keep
well,
getting information on my mail ID,
yeah,
can
give
I
me
put
your,
my mail ID on the
Facebook.
chat?
yeah, give me your email, I'll put you on the mailing list.
Can I put it on the chat or QA session?
Yeah, it's okay, yeah, send it to me.
On chat,
Yeah, right here, and right here in the chat would be fine. It's if you send it to me, let's see here, let me get your name, so.
S. Mathuria.
Suraj, okay, there you go, okay. Okay, that just comes to me.
So should I write on the chat?
Yeah, right on the chat.
Okay.
You're not wanted by the law.
Oh, no, I'll just do that. Oh, chat disabled.
Maybe I will say a greeting for Victor Hugo. First, Professor, how are you?
Hello.
Hey, you remember Fitri, Victor?
Professor, remember
Hello.
me?
Hello. How are you, Fitri?
I'm fine, thank you. How are you?
He was in
You are
Nepal
getting
with you, huh?
Yeah. No. With Victor, maybe in China,
Where are you from, Fitri?
Indonesia.
Oh, Indonesia. Yes, I was there about 2 years ago. I remember
With
you.
selfie.
Yes.
No, we meet with you.
No, last year.
No. No.
Okay.
It's long with Fink with Dolens. Do you remember? I have your picture and in the Turkey, Istanbul.
Okay.
Oh,
Very nice to see you.
Nice to see you also. Yeah, when we this is maybe my not experience, it's Yoha experience that he treated the youngest that because I'm a anesthesiologist, so he treated the youngest who has aneurysm is 2 years old
Wow.
in China. Beside maybe moya disease, a lot of cases is like a aneurysm or AVM, but the youngest who had aneurysm is 2 years old. That's why it's an interesting topic.
Very
It's good.
Okay, Pitchy, let me just wrap this up. We can talk after it's over. But thank you very much, Dr. Bata. And we look forward next week, the same time, for the same topic. And Victor, thanks for coming by, and thanks, Victor, for coming by. And I'll formally end the proceedings right now.
Thank you, Victor.
Stay there.
Thank you, Professor Atta.
I'm just taking
Thank
it
you.
off.